Hello everyone, and welcome to our first video for the series of the week number 1, which is the genitourinary pathology. In this section, we are going to go over the testicular tumors, and then we'll move on to go over the prostate tumors and prostate pathology, and then we'll go over the medical kidney as well as the renal tumors. And finally, we are gonna go over the adrenal gland pathology, which for some reason is included in the GU section in Kurt notes. So let's get started and start with the testicular tumors, and you'll kind of have a hint of how I approach everything. So here is the special thanks that I'm planning to include in every slide for Dr. Schaberg for giving me the permission to use the notes for educational purposes. And I'll start by talking about the outline. So the thing is, testicular tumors is kind of overlapping somehow with ovarian tumors when it comes to the GYN. Both of them are sharing a lot of entities like germ cell tumors, like choriocarcinoma is present here and there. However, of course, ovarian tumors has its separate entities like the serous carcinomas and this stuff, but they are sharing a lot of stuff. There is a whole bunch of tumors, and actually you will get faced with these two-stage questions in most of the Q banks. What's a two-stage question? Is this classic type of questions that we've been dealing with since we started our USMLE preparation back in years ago, which is like the question is focused on you reach a diagnosis, but the thing is the question is not in the diagnosis. The question is in a concept or a fact which is related to the diagnosed entity. Like let's say, for example, we're having a case of testicular tumor. Well, there's a testicular mass, and then here you go. You looked at the slide or you looked at the picture. Well, looks like a seminoma. Okay, the question will not be what's your diagnosis. The question will be in like an immunohistochemistry, which is specific for diagnosis, or a molecular signature for the tumor, or any concept or fact related to this, which I will cover in this section in the presentation, so goals for the boards. The goals for the boards, I'm going to go over the concepts that you need to know in each entity. But first, you need to identify each entity. You need to reach a diagnosis first. And reaching a diagnosis will be through the first section of this PowerPoint, which is the pearls for microscopic diagnosis. What is the key thing that your eye need to scan and look for in a picture or on a slide in order to say, well, spot diagnosis, this is seminoma. Spot diagnosis, this is germ cell in situ. Spot diagnosis, this embryonal carcinoma, whatsoever. And then after these pearls of microscopic diagnosis, I'll go over the second layer, which might help in some questions in confirming the diagnosis, which is the immunohistochemistry scheme. Because sometimes they give you a testicular mass and they tell you the immunohistochemistry. Well, this tumor was positive for this, and that. Okay, so I clearly identified a positive IHC, which helped me to confirm my diagnosis. So I'm ready now to see what the question is asking me about, and I'm gonna use this section for goals for the boards in order to solve the question related to the concept asked related to the tumor. And then we'll go over practical or practice by virtual slides, but this will be in a separate lecture. As I mentioned in my introduction video, I'm planning to make a separate session for virtual microscopy for each section. So let's get started, and let's start with the pearls for microscopic diagnosis. Well, at first we need to classify the testicular tumor, or what are the different entities of testicular tumor which are there. We have germ cell tumors, and we have sex cord tumors, And then we have paratesticular tumors, which arise actually not in the testis itself, but in the tissue around the testis. And then we have some other entities or other tumors that will be included at the end. It's like, you know, the completion of the story, the end of the story. And to be able to know the different entities in each subtype, you need at first to go back to the testicular anatomy and histology. Let's look at that. This is the classic histology of the testis. When you take a section of the testis, you have these seminiferous tubules. There we go. These are seminiferous tubules. And you have these septi in between the seminiferous tubules. These septi usually have these interstitial cells of Leydig, which we call Leydig cells. These interstitial cells of Leydig are the source of the testosterone, which is the male sex hormone. And then inside the seminiferous tubules, we have two flavors of cells. We have the spermatogenic cells, which are responsible for the production of the sperms or the spermatogones. And we have the Sertoli cells, which are the cells or the servants, the housekeepers for the spermatogenic cells. It adjusts the environment and adjusts the stuff inside the seminiferous tubule for proper spermatogenesis. Also, Sertoli cell has a key function, another key function, which is formation of the blood-testis barrier to isolate the sperms and the already formed spermatogones from the rest of the body, to keep them away from the eyes of the immune system, because the immune system doesn't know anything about it. Otherwise, it will react against these spermatogones, and it's going to be a big problem or a big trouble. So we have germinal epithelium here, which are spermatogenic epithelium, which include the germ cells, the spermatogenic cells, and stromal cells. The stromal cells include the Sertoli cells, which are present inside the seminiferous tubules, and the Leydig cells, which are there in these septi. And some fibrous connective tissue cells, like, okay, we have like fibrous septi, so definitely we're having fibroblasts, blah, 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 these fibrous connective tissue cells. And to remember the entities, see, like here they say myoid cells. Myoid cells, you have some muscle cells or some myoid cells in the septi in between the seminiferous tubules. It's good to correlate between the histology and the entities of testicular tumor that you have. Like, for example, please remember that you have germ cells, which include a sperm and an ovum. These germ cells form a baby or an embryo. And you have stromal cells, which include, as I mentioned, Leydig cells and Sertoli cells. This will make you like remember nearly most of the tumor. This embryo, to survive, it needs placenta for its survival. And one of the key structural components of the embryo that I need you to remember is the yolk sac and the disc, the embryonic disc. Do you remember the disc? The embryonic disc, which has these three layers, ectoderm, mesoderm, endoderm, from which the different tissues are produced. Why I'm telling you this? So that you are able to remember the entities of testicular cancers very easily. Like, see, so you have germ cells, right? Which are the spermatocytes. There is spermatocytic tumor. Perfect. You have an embryo, so there is embryonal or embryonal carcinoma. And you have a placenta, right? This make you remember the famous placental tumor entity, which is the choriocarcinoma. And you have yolk sac, right? So you have yolk sac tumor. And you have the trilaminar germ disc, which have the ecto, endo, and meso, these three layers. These three germ cell layers, or these three embryonic layers make you remember the famous tumor which arise having the three layer components, which is the teratoma. And then you have the stroma, which have the Leydig cells, so we have Leydig cell tumor, and Sertoli cells, so we have Sertoli cell tumor. This make you remember most of the entities: spermatocytic tumor, Leydig cell tumor, Sertoli cell tumor, yolk sac tumor, embryonal carcinoma, teratoma, choriocarcinoma, and of course, the sperm not only make you remember spermatocytic tumor, but also make you remember the famous entity, the seminoma, which coming from the semen, seminoma. So a good way to remember most of the entities which are present right here, like the germ cell tumor here, you have seminoma, embryonal carcinoma, choriocarcinoma, teratoma, spermatocytic tumor, yolk sac tumor. See, all of these are related to the formation of the embryo. And the sex cord tumor or the stromal tumor, this is coming from the stroma components that we were talking about earlier, which include Leydig cells, so Leydig cell tumor, Sertoli cells, which include Sertoli cell tumor. Almost you got most of them. And then there's some fibrous tissue component, so we can also call fibroma, for example, fibromathecoma. There is also granulosa cell tumor, which, by the way, a common entity between testicular cancers and ovarian cancers. Okay, makes sense. So I was able to remember the first point and the second point right now. Now I have only the third point to remember, which is the paratesticular tumor. And this you can remember from the anatomy of the testis. Very easy. Like I have the anatomy of that. I have the testis right there. And then we have this epididymis, right? And there is this red testis, and there is this epididymis, and then the vas deferens, and then you have the spermatic cord, right? The spermatic cord include all the blood supply, venous drainage, nerve supply of the testis. Well, so, and all of this stuff is covered by peritoneal fold. There is a peritoneal fold which is coming down because the testis is usually formed in the abdomen and it descends down to the scrotum. So it takes a peritoneal fold with it. So we have a fold of the peritoneum there, which is usually a potential space there, or it's completely obliterated and form what we call tunica vaginalis. So we have mesothelium coming from the peritoneum. Well, so we can have testicular mesothelioma, paratesticular mesothelioma from the mesothelium of the peritoneal fold. We can have tumors coming from the red testis, like adenoma, adenocarcinoma, and we have some paratesticular fat. So we might have some adipocytic tumors related to the paratesticular fat, and we will know all of that. So to remember these, the paratesticular tumors, you need just to correlate with the anatomy. You have the mesothelioma, you have adipocytic tumors, you have epididymis tumors, cystadenoma of the epididymis, or papillary cystadenoma of the epididymis. And then these other tumors I will leave to the end. So now we are able to classify testicular tumors by correlation with the histology and correlation with the anatomy. Let's now go over the germ cell tumor and start our journey with these ones. Well, germ cell tumor, as highlighted here in Kurt notes, they have three types. You have type 1, type 2, type 3. You need to remember that type 2 germ cell tumors are too common. Type 2 germ cell tumors are too common. They're the most common types of germ cell tumor. And these include all the famous entities that we're all familiar with, like the seminoma, embryonal carcinoma, choriocarcinoma, yolk sac tumor, and mixed germ cell tumor. These are the guys that we used to remember from the formation of the embryo, if you remember. There's also type 1, type 3. Type 3 is the spermatocytic tumor, not very common. And type 1 is the teratoma, mainly. there is a type of yolk sac tumor which is included in type 1, which is the prepubertal type, but we'll talk about that later. However, I need you to know from this slide that type 2 is too common. It's the most common type. And you need to know that all of these type 2 germ cell tumors are actually coming on top of an in situ component or an in situ tumor, in situ malignancy. You know this, like cervical cancer come from cervical carcinoma in situ, endometrial carcinoma is coming from endometrial intraepithelial neoplasia, or endometrial carcinoma in situ is the same thing. Here there is germ cell neoplasia in situ, or germ cell carcinoma in situ. They are all derived from a carcinoma in situ, these type 2 types. Type 2 is too common, and type 2 is associated with isochromosome 1,2, which is isochromosome 12p. This is a commonly asked fact in the questions in the Q banks. They ask about this isochromosome or isochrome 12p. It's associated with a lot of aneuploidy, frequent gain and losses of some chromosome, but the most key signature, genetic signature, is the overexpression of isochrome 12p. So type 2 is associated with isochrome 1,2. In the others, the type 1 and type 3, there is no isochrome 12p gains. There is no isochromosome 12p gains. There's the isochrome 12, there is no isochromosome 12. These are all malignant, they are responsive to therapy, which is pretty good. It has good prognosis. So we have 3 types of germ cell tumor, type 1, 2, 3. 2 is too common and derived from in situ and is associated with isochrome 1,2. Let's start by how we can identify germ cell tumors under the microscope. The first entity you need to know is when you see the contour of the seminiferous tubule is well preserved. See, the outer contour of the seminiferous tubule is well preserved. And then you have these seminiferous tubules, instead of being filled, look at that. See what's the difference? See the difference between these cells, the spermatogenic cells, which are normal, and these cells. These well-preserved seminiferous tubules is filled with these large cells. These large cells have this large angulated nuclei, which look like a rock, and a clear halo, a clear cytoplasmic halo around these angulated large nuclei. You're seeing these cells is occupying the whole seminiferous tubule, but still the contour of the seminiferous tubule is preserved. This means no invasion, so I'm dealing with germ cell neoplasia in situ. Second entity. Well, I feel like here the seminiferous tubule architecture is not well preserved. There are some cells which are taking over the testicular tissue and disrupting the architecture of the seminiferous tubule. So this means that we are having invasion here. We're now dealing with a frank carcinoma or a frank malignancy. However, the flavor of these malignant cells are kind of having these large cells, and the large cells are having this clear cytoplasm. You might have some pale eosinophilic cytoplasm in some instances, like this cell. See, like this cell, it has like a big nucleus. The cytoplasm is kind of retained, but having this pale eosinophilic. If there is any eosinophilic cytoplasm, it's pale, but usually most of the cells look clear, like as you see here. Large cells with a clear/pale eosinophilic cytoplasm. but still these cells, you can clearly appreciate the cell borders. There is a line representing the cell membrane. See, like I can see the cell border of each cell. And there are these fibrous septi in between these cells, which are making like islands. And these fibrous septi, this is a very important microscopic feature, infiltrated by lymphocytes. See, tumor infiltrating lymphocytes with lymphocytic infiltrate. So large cells, clear to pale eosinophilic cytoplasm, clear cell borders, fibrous septi with lymphocytic infiltrate. So you're dealing with a seminoma here. That's how seminoma looks like. Clear cells, large cells, fibrous septi, lymphocytic infiltrate in the fibrous septi. Another entity which look really disorganized is having this, I always say, columns. See, like the cells are kind of arranged like worms or like columns. You have this characteristic column or worm-like arrangement. So, and the second most important feature here is the color of the cytoplasm. When you look at the cytoplasm, you're having this amphophilic cytoplasm. This is a very important character here. Amphophilic cytoplasm means that it's not really eosinophilic, not really basophilic. It's a kind of in between. So it doesn't have this pink color, doesn't have this blue color. It's like a bluish pink. It's something in between. This classic amphophilic cytoplasm, and the cells are arranged in worm-like or column-like. And the cells, of course, the nuclei show clear nuclear pleomorphism and clearly prominent nucleoli, as you see right there. Extreme nuclear pleomorphism, as you see. So you are dealing with embryonal carcinoma. So embryonal carcinoma, you have these columns, worm-like arrangement, pleomorphic cells, large nuclei, prominent nucleoli, amphophilic cytoplasm. Please remember, amphophilic is embryonal. Then the characteristic appearance of choriocarcinoma is right there. You have these cells with clear borders and separated cells. These are called the cytotrophoblast, but these are not the characteristic cell. The characteristic cell is right there, which are cells having multiple nuclei, as if they are cells which are merged together. These cells which are merged together are characteristic also in a characteristic cell in the placenta. They call them the in situ trophoblast. In situ trophoblast. So you see in situ trophoblast, cytotrophoblast with hemorrhage, blood plus cyto plus in situ trophoblast. So you're dealing definitely with choriocarcinoma. Cytotrophoblast, in situ trophoblast, abundant hemorrhage. So you're dealing with a choriocarcinoma. The next entity is the one that always come with the characteristic Schiller-Duval bodies, although in the real life practice, you will rarely encounter a tumor with Schiller-Duval bodies. But they always have the classic picture for some reason. In most of the Q banks, they have this classic picture having this Schiller-Duval bodies or the hyaline globules to test you whether you know that these are the key microscopic features of this tumor or not. So this tumor has this classic Schiller-Duval bodies, which are the cells arranged around a central area or a central hyaline eosinophilic area in, I always say, in a sun-like appearance. It's like as if you're seeing a sun. It's a sun. Here is here is the core, the circle of the sun, and here are the sun rays, which are represented in this case by the cells arranged around this sun. It's a red sun, actually. It has this hyaline thing in the middle, and then the cells are arranged around these hyaline things. These are called the Schiller-Dovell bodies. Very important, very characteristic of this tumor. And the other thing which is characteristic of this tumor are these hyaline globules. Hyaline globules. These hyaline globules actually are alpha-fetoprotein, because the cells of this tumor secretes alpha-fetoprotein. So this alpha-fetoprotein will form these hyaline globules inside the tumor, which you see here as pink eosinophilic material there. So you see the hyaline globules, and you see the Schiller-Dovell bodies, and then you see the mass is always like yellowish in color. It's like the egg yolk. Remember, you have the egg yolk. The egg yolk reminds you of the egg. The egg reminds you of this yellow thing. So yellow mass with Schiller-Dovell bodies and hyaline globules. So you see these hyaline globules, Schiller-Dovell, and yellow mass. This is definitely a yolk sac tumor. Here are also some of these hyaline things. And of course, the Schiller-Dovell is very important. What's that? Well, you know what? I see some epithelium there, and I see something like which is really pink inside, which could be, I don't know, this is keratin, or is it like hyaline, or is it, can you go high power? Well, here is the high power here. The high power of this material is actually keratin, and you see these stratified squamous epithelial lining, and you sometimes see a lot of mature tissue there, like mature cartilage here, and some stratified squamous cysts lined by stratified squamous epithelium with keratin inside, and also you see these sometimes skin appendages there. Sometimes you see skin appendages there, like sweat glands, sebaceous glands. You sometimes also see bone, hair. This is what we call what? This is what we call the mature cystic teratoma, or the teratoma. Teratoma has the components of one or more of the germinal layers, epithelial slash mesenchymal. You might have some epithelial components, like these stratified squamous line cysts with keratin inside, and you might have mesenchymal components, like this cartilage and bone tissue, or even sometimes you have muscle cells, stromal cells. You have everything there. Teratoma, you know, can develop to any type of cancer, as we'll mention later. Teratoma, you might end up having squamous cell carcinoma in a teratoma. You might end up having papillary thyroid carcinoma in a teratoma on top of thyroid tissue, which is there. So any cancer might develop in the teratoma, as we'll mention later. But if you see the components of the different germ layers, you see cartilage, you see bone, you see skin, or you see stratified squamous epithelium with keratin, so you're definitely dealing with teratoma. Then, if you see these small, medium-sized, and large cells, so it's a whole bunch of different sizes of cells, but all these cells are sharing a common entity, which is having rounded blue nuclei. See, this has rounded blue nucleus. 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 So cells with rounded blue nuclei and of varying sizes, small, medium, or large cells with rounded blue nuclei. So you're dealing with spermatocytic tumor. This is the spermatocytic tumor, which is coming actually from the spermatocytes, or the spermatogenic cells, which actually look the same. When you look histologically, you'll see that the spermatogenic cells kind of look the same. They are having different sizes, and they have this rounded circular nucleus. Well, so it makes sense. These are the germ cell tumors, actually. We cover the whole germ cell tumors. So now you're able to identify any germ cell tumor by the key microscopic fact or the key microscopic feature that you need to look for. Sex cord tumors. Sex cord tumors, as we mentioned before, it include Leydig cell tumor, which I'm explaining here. I'll show you what's the key feature that you need to look for. And it also includes the Sertoli cell tumor and others. So let's look at the Leydig cell tumor first. The key microscopic feature in the Leydig cell tumor, which is always there in all the, for some reason, all Q-bank pictures, is having these crystals. They doesn't look like hyaline globules that we looked at before. Hyaline globules are more like rounded globular, and they are more pinky hyaline. This looks as if there is a crystal there. It's called Ranke crystal, Ranke pink crystals. And these are actually due to secretion of testosterone by these Leydig cell tumors, Leydig cell cells. So the protein also is accumulating and forming these Ranke pink crystals. This is called Ranke's crystals, Ranke's crystals. You can see it there accumulating inside the cytoplasm of some cells here, and here, and there. And you are having the background are cells with some grade of nuclear pleomorphism, and it's having this pink cytoplasm. So what's really characteristic here is seeing these Ranke's crystals. So the cells in the background are having abundant eosinophilic cytoplasm. The cytoplasm look kind of granular. Granular means as if you disperse granules or disperse pink eosinophilic granules in the cytoplasm of the cells. The cells are having prominent nucleoli, as you can see here, some grade of nuclear pleomorphism, which is not really much. This is Leydig cell tumor. See that? You're seeing cells with pale cytoplasm. They have this kind of tubular architecture, which look potentially like as if there is a one big, huge seminiferous tubule, which is split into smaller tubules. So we say always this tubular architecture. So there are cells, pale cytoplasm, tubular architectures. This looked like a seminoma. If I look at that, honestly, well, Mo, if I look at that, I will say seminoma because I see clear cells, as you mentioned, cells with clear cytoplasm, inside structures which are like tubules and they're taking over everything. They're having these fibrous septi in between. Well, okay, this is seminoma, but watch, look at this. There is no lymphocytes in the septi. This is a very, very important feature here. So when you look at seminoma, please look whether you have lymphocytes in the fibrous septi or not. Because in case of absence of lymphocytes in the fibrous septi, without lymphocytes, so you're dealing with Sertoli cell tumor. So see, the cells are also having pale cytoplasm. They have this kind of tubular architecture with these fibrous septi. And they are having stroma, which is extensively hyalinized. So there is fibrous septi or stroma. But if you look carefully in the stroma, you feel like this stroma is thickened. And sometimes in other tumors, it looks really clearly thickened and it's really pink. This is what we call hyalinized stroma. It is having hyalinized stroma. And there is no lymphocytes. Without any lymphocytes infiltrating these septi. This is called Sertoli cell tumor, which is the one on the top here. And the one in the bottom, if you see a lot of sclerosis, fibrosis, beside this hyalinosis, which is there in the stroma, you sometimes call it sclerosing Sertoli cell tumor. Because there is extensive sclerosis, extensive hyalinosis in the stroma in between the cells. This is called sclerosing Sertoli cell tumor. So I have Sertoli cell tumor in the top, sclerosing Sertoli cell tumor in the bottom. Clear cells, tubular architecture, hyalinizing stroma, no lymphocytes, please remember. This is the cold exner bodies. It's like the Schiller-Doval. You know, it's like when you see Schiller-Doval, oh, okay, this is yolk sac. And when you see these cold exner bodies, you say granulosa cell tumor. Always, even in the ovary, when we go over ovarian tumors, we'll see the same thing. We'll see these cold exner bodies, and we'll say, this is a characteristic of granulosa cell tumor. So the granulosa cell tumor are these cells with the classic coffee bean-like nuclei. I always say that. Coffee bean-like nuclei, the nuclei look like the bean of the coffee bean. The cells have these grooved nuclei, and the cells are forming circular bodies around also a pink core, like a sun, but they don't look the same as the Schiller-Doval bodies. They are called cold exner bodies. So you have these grooved nuclei, and see these, they are not well formed here, this cold exner body, and here's another cold exner body, and maybe that is another one, but not really much. But this one and this one are definitely cold exner. This is a high power field showing the cold exner bodies. So you see cold exner bodies, grooved nuclei in the cell. This is definitely granulosa cell tumor. I always say cold granny. You call your granny. Cold granny, cold exner bodies in granulosa cell tumor, just for you to remember. Some of the paratesticular neoplasms, the commonly seen ones, this one is very commonly asked in the Q-banks for some reason. And for some reason, I always miss this key microscopic feature in this entity. I hope I don't end up getting that in my board exam and I miss it as well. This is like, it's gonna be like, oh my God. This is a paratesticular neoplasm with these characteristic threads, characteristic threading or bridging. We call thread-like bridging strands. This is called adenomatoid tumor. It's usually come in the question as a paratesticular mass. That's a microcystic neoplasm having these microcystic gland-like spaces. It looks like as if you're dealing with acini here. It's as if you're having some acini here. So gland-like spaces, microcystic, with these characteristic threads, bridging threads, and always these bridging threads are there in the picture, in the Q-bank or in the boards. Thread-like bridging strands. This is called adenomatoid tumor. It usually comes, I think, from the peritoneum in the paratesticular area. I believe so. This is a paratesticular mesothelioma, not really high yield. I didn't see it that much in Q-banks. However, it looks like actually the mesothelioma of the pleura, having these epithelioid cells, epithelioid malignant cells, and it says always the mass is completely enveloping the testis. It's completely enveloping the testis. Like the same thing in mesothelioma of the lung, the mass is completely encircling the lung or enveloping the lung or enveloping half of the lung, which is the part which have the tumor in the pleura. So it's called the paratesticular mesothelioma. It's usually epithelioid type. You see these epithelioid cells with pleomorphic nuclei, not very high yield. You might see this is a papillary cystadenoma of the epididymis. Sometimes they make it very clear because they know how much it's difficult to diagnose this entity. They are saying that they usually give you in the question stem that the mass is arising from the epididymis, which is the structure surrounding the testis or around the testis. Or they tell you that there is a paratesticular mass, and here is the microscopic picture of the mass. And you see these papillae. You see these focal papillae there. These papillae are protruding in cystic spaces or cystic structures, and that's why they call it cystadenoma. So these cystic structures are lined by some clear cells or lined by some cells. So this is a cystadenoma. It has some papillary projection, so it's papillary cystadenoma of the epididymis. It exists in the epididymis. Sometimes you have rhabdomyosarc. It was asked in some Q banks. I honestly had a question about that in Path Primer. I remember that. It has these classic rhabdoid cells. Rhabdoid cells are actually muscle cells, right? Rhabdo, muscle. So you have these classic striations in the cytoplasm that you need to identify, or you need to have a bird eye. Oh, the focused eye, the bird eye. Oh, I see striations. I see this eosinophilic cytoplasm with striations in the cells. And the cells, of course, you can clearly appreciate how much the nuclei are very pleomorphic. There is clear nuclear pleomorphism. The nuclei are not of the same size, not of the same shape. There is this pink cytoplasm, and there's these striations in the cytoplasm, striated cells. These are the rhabdomyoblasts. So this is rhabdomyosarcoma of the testis, which is usually arising from the muscles surrounding the testis in the spermatic cord or in the paratesticular tissue. We're good. We cleared the first part of our lecture, which are the pearls for the microscopic diagnosis. So if you encounter a germ cell tumor, you know what you need to look at. If you encounter a sex cord tumor, you know what you need to look at. And you need to go over these microscopic pearls as many times as possible. So it helps you when you go over questions to easily identify the key microscopic features of each entity. Now let's go over the immunohistochemistry schemes. The schemes for the immunohistochemistry. So here is a table, which is actually there in Curt notes, which tell you the key immunohistochemistry for the germ cell tumor. What I need you to remember here, or what you need to start with here, is to remember that there are 3 stains which tell you that this is a germ cell tumor. They are positively in nearly all the germ cell tumor entities. These are BLAB, SAL4, and c-KIT. c-KIT, which is the KIT, I always say, which is CD117, actually. This is the c-KIT. So BLAB, SAL4, and c-KIT, or CD117. And to remember that, I need you to remember this mnemonic, which is Sally, play with the kit. You know the kit that you have if you have a kit to measure something. So Sally, play with the kits, with the kit. So Sally means SAL4, play, PLA means BLAB with the kit. So this make you remember the c-KIT, which is the CD117. These are the 3 immunos which are positive in nearly all the entities of the germ cell tumors. Then you have the one which is specific for each entity or for each separate entity. Oh, I need you to remember the beta HCG, of course, in choriocarcinoma. Can anybody remember what are the key microscopic features of choriocarcinoma? Cytotrophoblasts, in situ trophoblasts, and hemorrhage. This choriocarcinoma reminds you of the placenta. Placenta means placental hormone. Placental hormone is the pregnancy hormone, which is the beta HCG. See, the beta HCG is nearly positive only in choriocarcinoma, exclusively in choriocarcinoma. You need also to remember AFP for yolk sac tumor. Remember, yolk sac tumor had these hyaline bodies. The hyaline bodies were actually AFP, which is alpha-fetoprotein secreted by the tumor cells. So these tumor cells would be positive for AFP. So AFP, yolk sac, fetal, yolk sac of the fetus, yolk sac of the fetus, yolk sac of the fetus. The yolk sac reminds you of the fetus, so you have alpha-fetoprotein. So remember AFP for the yolk sac. And please remember CD30 for embryonal carcinoma. CD30 for embryonal carcinoma. Please remember that. It sometimes exists as the keyword, actually, because embryonal carcinoma can exist in a lot of different microscopic shapes and microscopic flavors. However, do you remember the key microscopic fact for embryonal? Amphiphilic cytoplasm. Remember these worm-like cells ranging course. Remember. Okay, so CD30 for embryonal carcinoma. There are other stains, of course, that you need to go over, like CK7. Well, there is OCT1 or OCT3/4. OCT3/4 is good at identifying seminoma, actually. OCT3 and 4 are very good in identifying seminoma. They are positive in seminoma and embryonal only. They're negative in the other entities of the germ cell tumor. But you know what? These are the key immunos that I need you to go over in germ cell tumor, at least as a start. Then sex cord tumors. There is also an immunohistochemistry pattern or immunohistochemistry panel that we ordered to confirm that this is a sex cord tumor. It's not a germ cell tumor, which actually come from the name 6 cord. But please modify from sex to 6. So 6 and then cord, the C in the cord. S stands for SF1, I stands for inhibin, and X is the X in the Fox. The X is in the Fox, which is Fox L2, and then cord C stands for calretinin. So SF1, inhibin, Fox L2, and carotinin. And please remember, this fact is commonly asked in the Q banks, that in Sertoli cell tumor, there is always nuclear beta-catenin staining. Nuclear beta-catenin staining in Sertoli cell tumor. This beta-catenin is not calretinin. This is different. Nuclear beta-catenin is there in Sertoli cell tumor. I always say the cat is in the nucleus, sir. The cat is in the nucleus, sir. So the cat, which is the catenin, beta-catenin, is in the nucleus. This means it's nuclear beta-catenin, sir, which is Sertoli cell tumor. So to remember that in the Sertoli cell tumor, you have the beta-catenin in the nucleus. So there is nuclear beta-catenin staining in Sertoli cell tumor. These are all the facts that you need to know for the immunohistochemistry. Now we'll go over the goals for the boards in part 2 of this video. So see you in a while.